Hello, everybody, and welcome to today's webinar titled Molecular Diagnostic Approaches to Accelerate and Improve STI Diagnostics. I am Teddy Proctor, a Senior Scientific Affairs Manager in the Genetic Sciences Division of Thermo Fisher Scientific, and I'll be your moderator for today's event. Today's educational webinar is presented by LabRoots and sponsored by Thermo Fisher Scientific. To learn more, you can visit our website at thermofisher.com. I'm very pleased to introduce our speakers for today's webinar. First, we will hear from Dr. Vanderpool. She is a professor of medicine and public health at the University of Alabama at Birmingham and is the director of the UAB STD Diagnostic Laboratory. She has been active in the field of biology, epidemiology, and diagnostics of sexually transmitted infections for 40 years. Her behavioral research focuses on delivery, utilization, and implementation of new diagnostic technologies. Dr. Vanderpool currently serves as the president of the International Society for STD Research. Our next speaker is Beena Sontag, who holds dual master's degrees from University of Mumbai in life sciences and from San Jose State University in biotechnology. She has 16 years of experience in the life sciences industry. She started her career in tech and global product support and then transitioned to product management, where she oversaw implementation of application at key customer sites, managed global communications within the reproductive health divisions, and coordinated action plans for customers with urgent support needs. Since transitioning to product management, she has managed and launched various products covering research, infectious disease, and clinical application. She is currently a senior product manager at Thermo Fisher Scientific. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, you simply type them into the Ask a Question box and click Send. We will answer as many questions as we have time for at the end of the presentation. If you have any technical issues during the presentation, you may submit your issues through the same manner. For a complete biography on our speaker, please visit the presenter window at the top of your screen. I would like to now welcome our first speaker, Dr. Vanderpool, who will share her expertise about STI testing and screening. Dr. Vanderpool, you may now begin your presentation.
I'm going to talk to you today about STIs specifically and what the options are and what you should be offering to your clients, because this is an ever-evolving landscape and there's a lot of issues associated with what choices you want to make. I always do start with a disclosure slide. I work with a large number of manufacturers as well as government agencies through grants to my institution as well as consulting fees that I receive personally. So I'm going to cover a few topics today. I'll focus mostly on pathogens and the way that we diagnose those pathogens. I'm not going to talk a lot about diagnostic methodologies because I think probably most of you are familiar with those, but I'll be happy to take any questions on those topics if you have them. I'm going to talk about sample types that can be used for this testing, and then I'll end up talking about the ways that we can collect samples in today's world. So let's get started with the menu. So I'm going to focus first, and most importantly, in my opinion, on STIs that can be detected with molecular technologies or nucleic acid amplification tests. I'm going to give you a little bit of the epidemiology of the things that I have on this particular slide, just so that you'll remember why you get large volumes of these requests. So to start with chlamydia and gonorrhea, it's important to remember that these two infections alone account for over 80% of all non-COVID notifiable infections. That's a lot. These are highly prevalent infections, and that's why we have screening programs, which I'll discuss in just a minute what the recommendations for screening are. Chlamydia is predominantly asymptomatic, which again is why we have screening programs where I use screening to talk about testing asymptomatic populations based on predetermined criteria, but not symptoms per se. Gonorrhea is often less commonly asymptomatic, especially in men, but women still do have asymptomatic infection. Trichomonas, which is caused by Trichomonas vaginalis, can be, we often hear trichomoniasis, and this is more common than chlamydia and gonorrhea combined in many populations. And so it's really important that we consider testing for this when we test for chlamydia and gonorrhea. And most tests that are commercially available now do have a trichomonas testing option. I don't say trichomoniasis for the most part because as many as half of these infections may be asymptomatic. And that means that people don't have trichomoniasis, which is the inflation and infiltrate that's caused by that, but they do carry the disease. And it has outcomes during pregnancy and risk for HIV that are similar to those related to chlamydia. And the prevalence is much higher, so it's an important pathogen for us to think about. Mycoplasma genitalium, you've probably been hearing a lot about for the last 2 to 5 years. I've been testing for it for over a decade. The problem with it is we don't have great data from an epidemiologic perspective to associate this infection with downstream outcomes. So we're not really 100% sure that treating patients offers an advantage in protecting them or in protecting women and neonates during pregnancy. It's important to think about the fact that 40 to 80% of Mycoplasma genitalium detected in this country, which isn't a lot, we don't test everybody, but 40 to 80% of those cases have a resistance marker to macrolides, and those are the antibiotic class that's used for treating chlamydia. So we may be driving resistant Mycoplasma genitalium in our chlamydia control efforts, and I'll talk more about that in a bit. Finally, on this slide, I've included causes of vaginitis because this is the single most common reason that women seek health care. And obviously, we would do testing for women only in those women who had symptoms because BV, as you know, is an imbalance in many of the organisms that are commonly commensals in the vaginal microbiome. And the same thing obviously is true with Candida species that may be present normally, but when the woman is symptomatic, that means there's an overabundance of some of these bugs, and that's causing problems. So that's diagnostics that should be done, not screening, because it should only be done in symptomatic women. And I mentioned that I would go over the CDC guidelines, and I'll start with chlamydia because it's one of the ones that we have the clearest cut guidelines for. In this case, because of the asymptomatic nature of infection, we recommend screening for women, any woman under the age of 25, regardless of sexual behaviors, regardless of numbers of partners, regardless of new partners, really regardless of anything. If you're under the age of 25, you should be offered chlamydia screening every year at an annual healthcare visit. But also in women without symptoms, the CDC recommends screening in certain cases. And I've called this for cause. And in green here, I'm showing what those for cause reasons are. We define those as people living in a high prevalence population, which often the lab can't know. So this is really difficult for us. Having a new partner, having an infected partner, which again, the lab is not going to know, and people who are on PrEP, where recommendations exist for screening those people 3 to 4 times per year. Obviously, diagnostic testing should be performed on anyone who has symptoms related to chlamydia, which you're going to see these are the same symptoms for all of these bugs: discharge, dysuria, and other related symptoms like pelvic pain, tenderness, so on and so forth. Okay, so Neisseria gonorrhea, which we usually in this country test for with chlamydia, in Europe they don't test for as a routine necessarily because asymptomatic screening is not actually recommended. Now again, that's screening for cause, if you live in a high prevalence population, so on and so forth, is appropriate. And obviously testing anyone with signs and symptoms is appropriate. So we often bundle chlamydia and gonorrhea here, and we do find a lot of asymptomatic cases, which is why it's the second most common notifiable infection. Trichomonas vaginalis, which by the way is not a notifiable infection, which is why we don't have good epidemiologic data on that organism. But the CDC guidelines only recommend screening women who hit those for cause categories. So essentially this is the same as for gonorrhea. However, they only recommend testing in symptomatic people if chlamydia and gonorrhea have already been ruled out. We'll see in a minute that because trichomonas is so prevalent and because chlamydia, gonorrhea, and trichomonas can be often occurring in the same patient, most of the people that I work with have decided to just include chlamydia, gonorrhea, and trichomonas, 3-part screening for women who have symptoms. So sorry, that's not screening, that's diagnostics. Now for Mycoplasma genitalium, the CDC does not recommend screening. And to be clear, I'm not saying they don't have recommendations about when you screen. Their recommendations say you should not screen asymptomatic people. Again, that's because we don't know the best treatment and we don't have data that's convincing data that there are adverse outcomes to untreated asymptomatic infection. And for people who present with symptoms, they recommend Mycoplasma genitalium testing only for those who have failed chlamydia gonorrhea treatment or were negative for chlamydia gonorrhea after testing. Now, this obviously involves 2 patient visits and a lot of extra clinical healthcare resources to be utilized. So it's not an ideal situation. But again, as I mentioned earlier, we have antimicrobial resistance issues with this organism, and so treating it can be problematic. I told you I would share with you information about co-infections, and this is really great data from Damon Getman and colleagues several years ago. It's important to remember that first, this is from symptomatic patients only. So we're looking here not at the prevalence rates of these diseases, but if a symptomatic person comes in, the proportion of those people that have these infections. And what you see for women, shown here in green, is that the vast majority of them have trichomonas, which again is why many situations in clinical settings and STD control programs automatically test for trichomonas when they test for chlamydia and gonorrhea. Interestingly, Mycoplasma genitalium is the second most common, and chlamydia comes down here as a very far and distant third. And again, this is patients with symptoms. You'll see that GC alone is very rare, but it also occurs with other infections. So testing for all 3 or even 4 pathogens, if you want to include Mycoplasma genitalium among symptomatic people, may be warranted. We just need initial data about what's happening with people who have symptomatic mycoplasma infections. And the guidelines for CDC do require that you use an antimicrobial resistance marker detection assay. We don't have any of those available in the US. If you're working in Europe and you have access to those assays, then you're much better ahead because you can make targeted decision about how to treat people. For men on the right, you can see that the most common infection is chlamydia, followed by mycoplasma. But interestingly, trichomonas is very common in men who have symptoms, 14 to 15%. So don't forget that testing those people for trichomonas while they're at that initial visit so that you can treat them appropriately the first time may be warranted. So that's what we know about co-infections. And I did mention earlier that we should be considering causes of vaginitis when we're testing patients, women that have symptoms. And this is just a study to show that the data are quite strong, showing that if you have, for example, bacterial vaginosis, 17% of those people are going to also have an STI. So doing just vaginitis testing or just STI testing doesn't tell you the whole picture of what's going on in a woman with symptoms. I did want to mention a few other pathogens that you can put into bundles. I've already said our process of bundling chlamydia gonorrhea may not be ideal, and it's not always that way in Europe. Also, that bundling in mycoplasma doesn't make sense because you're testing a lot of asymptomatic people. But I wanted to talk about some of the other assays that are commonly offered from either a urine specimen or a vaginal swab. The first of these is herpes simplex virus, but I would argue that if that's from a urine specimen or a vaginal swab that's not directed to a lesion, those results are likely uninterpretable by the clinician. The reason for that is if you get a positive result, it's probably a true positive, but it may be detecting asymptomatic shedding. And in that case, the provider is not going to want to provide suppressive therapy. So that result wasn't helpful. If, on the other hand, the result is negative, that doesn't mean that the person doesn't have HSV, because we know that HSV can occur in what we call that boxer short region. So it might not be located in the vagina, and it might not be located in the urethra from which the urine was provided. If that's the case, the negative result is again accurate because we can only detect what's in the specimen, but the result's not meaningful. And so especially when we start talking about remote sample collection and lab-based testing, this is one that offering is probably fraught with difficulties, and you should really consider. Excuse me. So other things that we should consider. A lot of people have been asking about syphilis PCR lately, and they would really like a solution that's molecular for detecting syphilis. The problem with that is we don't have enough data to tell us where the spirochetes are during different stages of the disease, which does go through very specific developmental stages. So one of the problems is that if a person has a positive result, again, it's probably meaningful, but a negative result is probably not. So if we have a urine specimen that gives us no syphilis DNA, that doesn't mean the person doesn't have syphilis. And I apologize for all those double negatives. But the reality is that this is not ready for prime time yet, and people will keep working on that. But until we know where the spirochetes actually are during the various stages of infection, it's very hard to develop an assay that's useful for detecting syphilis with molecular technologies. And then I want to just briefly say Mycoplasma hominis and the ureaplasma species, Ureaplasma ureolyticum and Ureaplasma parvum, have not been shown to be associated with negative outcomes either during pregnancy or related to fertility or development of epididymitis or proctitis. So there's not really a great incentive for treating those. And in fact, what we know about Mycoplasma hominis is that it increases in organism load during episodes of BV, but it decreases in organism load in response to treatment for Gardnerella vaginalis. Now, Mycoplasma hominis doesn't respond, it's not susceptible to that class of treatment, and yet the organism load decreases. We think this is probably because the organism is happily replicating inside the biofilm created by Gardnerella, and when that biofilm goes away, that replication environment's no longer as friendly and the organism load goes down. But my point here is we have to be cautious that just because there's an epidemiologic association doesn't mean it's causal, and doesn't mean that we want to do diagnostics, and certainly doesn't mean that we want to engage in therapy for these infections if they're not really infections. So I'm just showing here, again, I'm not going to talk a lot about methodologies, because if you have a lab and you're already doing this, then it's all good. But this is the sort of scope and range that we have right now. We go from the mini school bus size shown here on the upper left down to something that you could hold in the palm of your hand. So it's all fine that you can use these different point of care options to a lab-based option, and even these point of care options can be used in a laboratory. So I just want to say a word, since I've mentioned point of care, I want to say a word about antimicrobial resistance markers. And there have been a lot of people recently who've been saying that antimicrobial resistance marker testing is only useful at the point of care, so the patient can be treated before they leave. And while that's a great thing for gonorrhea, and in fact we know that if you use a gonorrhea test at the point of care, and you can detect that the JAR-A gene is wild type, it's susceptible to ciprofloxacin. So you can treat patients with an oral therapy rather than having to use an injectable like ceftriaxone, which is currently the recommended treatment scheme. So yes, at point of care, that works great. And here's an example of one of the assays that's sort of in development, where you would have just a little box that would tell you in red here that the gonorrhea is present. In blue, you see that it's wild type, so you could treat with ciprofloxacin. In the middle panel, you don't see that blue line, so you would have to use ceftriaxone. And in the far right line, you see that there's actually no gonorrhea in there, so you didn't have to treat. Of course, the problem with this is it's only testing for gonorrhea. So you don't know about chlamydia or trichomonas or mycoplasma. So that's where the lab is always going to have to come in and backstop whatever the point of care options aren't telling the provider. So lab-based testing, excuse me, is also appropriate for Mycoplasma genitalium always. Because in Australia, they've adopted a staged program of treatment, which they call resistance guided therapy, where you test people first, you give them doxycycline, and again, this is only symptomatic people, doxycycline for 7 days. You look at the test results. If mycoplasma is not there, if they have trick, you still need to treat the trick because the doxycycline wouldn't have done it. If they have gonorrhea, obviously you need to treat that. But if they have mycoplasma as well as any of those other things, you need to treat depending on the macrolide resistance marker results. So if they have wild type, you can use azithromycin, and they had a 95% success rate in this large clinical trial. If they do have the markers saying that they're resistant to macrolides, you can treat with moxifloxacin, which is A, more expensive, and B, has worse side effects. So it's not what you want to go to as your first line therapy. But then they still have a 92% plus cure rate. So it's really awesome. So now I'm going to change topics from molecular diagnostics, sort of, to serology. And I say sort of because with HIV, as you all know, serology is the routine screening diagnostic method, usually with a generation 4 or 5 antibody antigen combination serology test. But more and more, we're starting to need RNA, viral load, molecular testing, because many of the people being tested now are on PrEP, which means they were tested recently, let's say within the last 3 months. So you're looking for incident infection. If you're looking for incident infection every 3 months, you might be looking before a person actually develops antibodies. And so therefore, something that can detect the actual organism is probably more useful. For syphilis, serology remains the most common and the appropriate diagnostic method. There are two types of serology that you have to do: treponemal specific antibodies that will be positive for a lifetime if you've ever had syphilis, even if it was treated, and non-treponemal antibodies, which the serology tells you if the person has an infection, but doesn't necessarily identify it as a syphilis infection, which is why you have to have both. And you can do the reverse algorithm, which is the order that I've shown here: treponemal followed by non-treponemal. If you have a low prevalence population, that probably is cost savings. But if you have a high prevalence population, you're going to have a lot of people that are going to have treponema positive results. So probably starting with the non-treponemal test is more important and probably saves you some money. Okay. Hepatitis B and C, we're still obviously doing serology tests to detect these. Although again, with hepatitis C, we're moving into that molecular realm where we want to see viral loads in order to determine whether it's an active infection. And then again, a word about herpes, sort of the STI problem child, if you will. Herpes serology is kind of fraught with difficulty. Probably it makes sense to do only antibodies specific to HSV2. However, none of the tests that we have are supremely sensitive or specific. And so what you need to do is you need to confirm that it really is HSV2 and not antibodies to HSV1 that might be cross-reacting. So confirmation is absolutely required if you're offering this test. And if you're not offering this test, think twice before you offer it, because really HSV antibodies aren't terribly meaningful clinically again. So if a person is positive for HSV2 antibodies, if they don't have lesions, then you're not going to treat them based on that positivity. If they were somebody that you were going to test anyway, clinically, you're probably already counseling them about how to protect themselves and how to protect their partners from HSV transmission. If they do have lesions and you do the test, but the HSV2 test is negative, that's not very meaningful either, because more than half of genital herpes is now caused by HSV1. But of course, as we know, since cold sores can also give you antibodies to HSV1, testing for HSV1 doesn't make sense. So all the way around, herpes is just really fraught with difficulty, and one should use caution before adopting it. So what are you supposed to be offering? Because that's part of what I said I would tell you. Well, I can't tell you. First of all, though, you have to disentangle screening from diagnostics, which we've never had to do for chlamydia, gonorrhea, but because mycoplasma is out there now, you probably need to start asking for information from providers about the symptomatic status of patients. You should have a full menu so that you can offer your clients whatever they want, but you probably shouldn't do automatic bundling. And you'll need to really work with your clinician colleagues to try and decide what's best in terms of tests that you offer in terms of patient outcomes. I think that this is becoming more important than it's ever been before in the STD arena. So with that, having not answered your questions at all, let me transfer over and talk for a minute about sample types. So in 2009, we actually wrote guidelines for laboratory diagnostics. It took 5 years to get them published, and they were released in 2014. But a lot has changed since then. So we say a couple of things. Even in 2009, we knew vaginal swabs were the optimal specimen type. We knew that male urine was the preferred specimen type to invasive urethral swabs, but in green here I put something that's not in the guidelines, which is that meatal swabs may be useful. We need to do more work on that. So right now, only one assay has a claim for meatal swabs and only for one pathogen. So meatal swabs aren't ready for prime time, but be thinking about them because they're probably going to come your way. Anal, rectal, and oral pharyngeal sampling is quite important. If you're doing oral pharyngeal sampling, you do need to make sure that people are aware that they can't do a buccal swab. It has to be a tonsillar pill-eye swab. And again, not in 2009's guidelines, but the things that we know today is that we don't have anywhere near enough data to make recommendations about the best anatomical sites to sample in trans persons. I just wanted to give you a little bit of data about why I even talk about sample types, and I'm really pretty passionate about this. But in a survey done in 2020, still over half of samples coming into public health labs for STI screening from women were urine. And I've shown here a bar graph that shows you in red the sensitivity of vaginal samples and in yellow the sensitivity of urine. And these sensitivities are statistically different. And it's important that we offer the best service that we can to our clients. So offering vaginal swabs is quite important. But if you have to offer urine, and there are times when it makes sense, but if you have to order urine, please do not send residual clean catch urine, because these are terrible sample types. All of the material that we want to detect for STIs is in that first void portion. So when we look at the numbers, this great study from Pickett and colleagues showed that compared to vaginal swabs, a clean catch urine is missing 20% of infections. That's not good health care. That's not what we want to offer patients. So if you have a lot of clients that are still sending you urine from people who have a vagina, ask for vaginal swabs and share with them data and explain to them why it's important. And in fact, if they use self-collected swabs, which I'll get to in a minute, they can actually improve their clinic flow. I did mention that you should be doing extragenital sampling, and here I show you data from 14,000 visits to a health department clinic in Indianapolis. And in this study, anybody who reported receptive anal intercourse was sampled. And what we saw is that if you don't sample the anal rectal specimens from men, you would miss 70% of chlamydial infections. You would miss over half of gonococcal infections in men. Now, in women, these numbers are much less striking. Most women's rectal infections are likely auto-inoculation. And the other thing, I'm not showing the pharyngeal data here because we did pharyngeal testing, but what we found was that the vast majority of people that had an infection in the pharynx also had either a rectal or a genital infection. And so doing those two sample types was likely enough to get the vast majority of infections. So again, when you're doing extragenital testing, you need to avoid the bundling. It's really a consistent message I'm trying to share with you here. For chlamydia and gonorrhea, it's quite easy. 3-site testing is recommended based on the exposures of the patient. And again, as a laboratory, you don't know this, but it's helpful sometimes if you can share this with your clinician colleagues. It's important that they not order trichomonas routinely because we don't really have a sense of the meaning of a trichomonas positive in a rectal sample and a throat sample. There are commensal organisms that may cross-react in some of these assays. They've not been validated. They don't have claims. So this is something that's probably useful for genital testing only. And then for mycoplasma, again, the genital testing is limited to those people who meet the right criteria. Anal testing is done a lot, especially in places like Australia. And in gay men, you will find a lot of mycoplasma. You will also find that almost all of it is resistant. So these people would predominantly need moxifloxacin treatment, but we don't have the tools yet in this country to allow us to offer that AMR testing. And therefore, since people don't really know how to treat it, most health departments are not recommending it, and the CDC certainly isn't. So one of the things that we clearly need is AMR detection. Okay, I told you I would move to self-collection, and that's what I want to end by talking about for a few minutes. And essentially, self-collection can be done in a clinical setting, which is what everybody has claims for vaginal swabs, nothing else. Well, urine, of course. But really, self-collection can be done in non-clinical settings as well, but unfortunately, none of the assays that we have those claims. And we'll talk more about that in a second. I do want to be very clear that I'm not talking about self-testing here. Self-testing is when the end user collects their own sample, does the own test, and interprets their own results, all without input from a healthcare professional. So these are not here yet, but they're on the way. So be prepared, because you're going to have people coming in that you're going to be testing that tested themselves at home. And when the results aren't the same, the lab is going to hear about it. So you need to know that it's coming. So self-collection in a non-clinical setting is really not new at all. We've been doing this with groups that I've worked with since the late 90s, and we've never had an adverse event reported, including working with adolescents. This is easy, this is safe, the results are appropriate and just work the same as things collected in a clinical setting. It is recommended that self-collection can be done since 2009's guidelines, but again, that was in a clinical setting. It's recommended by WHO as part of their self-care initiative. And self-collection, even in a clinical setting, is considered to be cost-effective. It's cheaper to have the patient go into the bathroom, provide a urine if they're providing a urine, provide a vaginal swab, and then go back to the waiting room or wherever until they wait and interact with the provider. And that saves time on the provider's part because those specimens are already sitting there waiting. Once we have point of care tests, which we do now, in fact, those tests can actually be run. Sometimes the results can be available to the provider before the patient even goes into the room. So it can really improve flow, and there are cost savings associated with it. As far as extragenital testing goes, again, assays have claims for these sample types, but not for self-collection. And so that's something to be aware of. In most cases, we sort of don't ask, don't tell in the lab, because we know that most patients prefer to collect their own rectal sample, and most providers prefer to allow them to do that. And this is just from a study up in Indianapolis where we asked people to do this and then asked them what they wanted to do in the future. And most of them wanted to do their own sampling. Throat sampling is a little bit dicier because people might give you buccal samples and then a negative isn't terribly meaningful, but you need good collection instructions if this is going to be adopted. And although this is a clinical activity, often providers will look to the lab and say, can you give us instructions for how to collect these? So laboratorians need to know what the best way to collect these samples is. And many places have resources like the one shown here. Some places even use videos that the patient can watch the video as they're actually doing it and look in the mirror and make sure that they're doing the thing correctly. So lots of resources out there for doing this. So let me wrap up and just remind you that one size really doesn't fit all. And while we try to give our clients everything that they want, That's going to vary. It's going to depend on your client base. And I think it's really important that the lab work with providers so that providers really understand exactly what's being offered and for whom it's appropriate. Avoid bundling. Even if your platform does it and you're offering a full menu, which is wise, you probably need to avoid bundling. Trichomonas should be encouraged in most people. Vaginitis should be encouraged in symptomatic women, but Mycoplasma genitalium testing should be discouraged. So it's quite complicated. It's just never as easy as we would like it to be. So you should offer all sample types positive. You should discourage routine use of urine from anyone who has a vagina because you should get vaginal samples. You should consider the sexual routes of exposure, but you in the lab don't know. So again, this is where you're working with the provider to say, if you have clients who engage in receptive anal intercourse, our lab can support testing anal rectal samples. And again, as I mentioned earlier, a lot of people have these infections in the rectal compartment that wouldn't be detected by genital testing. And while I personally don't find oral pharyngeal testing to be really cost effective or productive, a lot of people ask for it. So I provide it, but again, only for chlamydia and gonorrhea.
Dr. Vanderpool, thank you very much for that interesting overview and your insights about testing. Now we will hear from Bina on the TaqPath Menu GeneProof assay options. Bina, you may begin.
Thank you so much, Teddy, and thank you, Dr. Vanderpool, for a great presentation. As you all heard, the importance of clinical STI testing and how prompt and early diagnosis of sexually transmitted infections is important to enable appropriate treatment and help prevent further transmission. Clinical testing labs require STI testing solutions that help provide confidence, fast turnaround time, and accurate results. I would like to present our TaqPath Menu GeneProof STI portfolio that will enable everyone testing of STI pathogens. Here is our offering of the 11 STI PCR products. As you can see, we offer a solution to our customers which supports sexual health testing with CE marked sexually transmitted infection assays designed to provide accurate, reliable results with excellent sensitivity and specificity across a wide variety of pathogens. You can see here we have pathogens ranging from chlamydia trachomatis to Gardnerella vaginalis, herpes simplex viruses, human papillomavirus, etc. We offer singleplex as well as a few multiplex assays. You can see we support multiple sample types from swab, urine to sperm, and all of them have been validated with the respective assay kits as mentioned here on the slide. This is the authorized workflow, which is a standard workflow used with real PCR assay. Once you receive samples, the samples are extracted and the specimens are prepared according to the instructions for use. Following use of the TaqPath Menu GeneProof assays on the validated PCR instruments such as the Applied Biosystem 7500, Corn Studio 3 and Corn Studio 5 real-time PCR systems. The analysis and interpretation is according to the IFU. Now let's talk about the benefits of the TaqPath Menu GeneProof products that we now have available in our Thermo Fisher Scientific genetic testing solutions portfolio. When it comes to the new TaqPath Menu GeneProof PCR kits, there are several benefits. Some of these benefits are quite unique. As you can see, we have a simple PCR kit content, one workflow, ready-to-use master mix, unique internal control, contamination prevention system, and a wide range of verified specimens and instruments. Let's deep dive into each of these features on the next few slides. Simple kit content. As previously mentioned, one of the benefits is having a simple kit content. When I say simple kit content, I mean that the kit contains ready-to-use master mix, internal control, and positive control in case of qualitative PCR kits. And in case of the quantitative PCR kits, instead of the positive control, the kit will contain calibrators as indicated here, such as A, B, C, and D. The advantage of the simple kit content is that the users do not need to mix their own master mix from several components, unlike other manufacturers that use lyophilized reagents and then need to prepare a working solution before adding that to the sample and other components in the PCR assay. This provides, the customer ease of use and a quick, workflow to, enable, the assay quickly. One workflow. This is one of the best features we offer through our portfolio. One workflow is important because it means that we have a universal PCR profile that is validated for majority of our PCR kits. This PCR profile works for RNA and DNA pathogens. And with a universal PCR profile, we can easily combine different assays in a single run. So we can combine assays from the same diagnostic group or combine different assays from different diagnostic groups in one run. Here as an example, you can see we can easily detect chlamydia or HIV or HPV or any other pathogens in a single run, thanks to the benefit of having one universal PCR profile. For lab users, this is extremely useful and helpful for routine diagnostics, as a single run can involve many material types and many results which examine RNA and DNA pathogens at the same time. This is another example of the one workflow, and here I'm showing an example of how we can use it to detect a causal agent for urethritis. Since there are many different pathogens that can cause urethritis, it is very beneficial to combine several assays in a single run. As the previous example, samples are typically obtained by either swab or urine or the validated sample type for that particular kit. Again, we will add the universal internal control directly to these samples. So it's just one universal control for all the 3 PCR kits as an example here. Extraction is performed, and by using 3 assays and one universal PCR profile, we can combine a singleplex and multiplex assays together in a single run. In this example, we are running the MHUUUP multiplex with the CT-NG-MG multiplex and a singleplex of Trichomonas vaginalis. As you can see, the benefit with just this one PCR profile and a combination of all these different assays in a single run, in the end, a user would see 7 different results for for that particular run. Here are several sample types that have been validated for each of the assays, and you can see all these assays have a single universal PCR profile that can be supported as an example on a QuantStudio 5 system. You can see it not only supports the STI portfolio, but we have other portfolios coming up such as respiratory, hepatitis, and the HSV portfolio. So there are multiple different assays from different diagnostic infectious diseases that can be run together with one universal PCR profile on a particular instrument. Another benefit is the ready-to-use master mix, which provides users all the necessary reagents for a PCR reaction. The ready-to-use master mix simplifies the laboratory workflow for routine diagnostics. This means users simply just need to add the extracted DNA or RNA to the master mix and then set up their PCR run. As mentioned, the Applied Biosystems TaqPath GeneProof Universal Internal Control is a separate product that can be ordered. It is a mixture of the internal controls from different PCR kits in a single tube. It's really very useful, especially when you're combining, more assays in a single round. Of course, if you do not need to use it for a particular run for a single assays, you can use your specific internal control that is already provided as part of the PCR kit. However, if you want to combine and simultaneously detect more pathogens in a single run or combine more assays from different diagnostic groups in a single run, the TaqPath Menu Universal Internal Control is an excellent option for you to use to enable that. A major issue in laboratories is the problem of contamination. To try to prevent contaminations, we include two components in the ready-to-use master mix. By including an enzyme and uridine-3 phosphates in the ready-to-use master mix, we can avoid false positive results and can easily prevent contaminations from carryovers from previous amplification. So this definitely helps users to solve the problem of contamination. Our PCR kits are validated for use in a wide range of PCR cyclers. You can refer to the instructions of use where you can see the list of PCR instruments that are validated. Here is an example of the PCR instruments provided by Thermo Fisher that are validated for the assays. We have the Corn Studio 5, the Corn Studio 3 PCR system. We have the Applied Biosystems 7300 and 7500 PCR system. And then we also have the Step 1 and Step 1 Plus real-time PCR systems that are validated on the TaqPath Menu GeneProof assays. So what's next? We went through the portfolio of our STI products, and I'm excited to show you that along with the STI portfolio, we will be launching kits from other infectious diseases too. This year we'll have around 37 PCR kits that will be launched in different phases. We've already launched the STI portfolio. We've launched the HIV type 1 assay. Just last week, we launched the respiratory infections and the hepatitis portfolio. And then coming soon, we would be launching the immunocompromised and the genetic tests portfolio for the most common thrombotic mutations. So you can visit our website to get more information on the different diseases. We have web pages that will provide you additional information for your review. So as we're launching additional assays throughout this year, this is just a preview of the different validated samples that have been verified and validated across the different portfolios. As you can see, apart from urine swab, we also have plasma, serum, aspirate, sputum, whole blood. Please refer to the instructions for use to verify which samples are validated per infectious disease kit. I just wanted to show you that there is a wide range of specimens that have been validated on our TaqPath Menu GeneProof PCR kits portfolio. Thank you so much for listening to me. With that, I'll hand over the mic to Teddy for live question and answers.
Thank you, Bina, so much for that informative presentation. Now we'll move on to the question and answer session. We have a couple questions that have come in already, but please feel free to add your questions. You can do so on the left-hand side. Click the Ask the Question icon. Go ahead and type in your question, and we will get to as many questions as we have time for. So we will start with our first question, and it will go to Bobby. So it seems that recommendations for testing for trichomonas are somewhat vague. Who actually should we be testing?
That's a really helpful question because I think the answer is it depends. So it's always so hard to answer, a one size fits all, which is unfortunate. But if you serve populations where the rates are high, So it's hard for the lab to know where the specimens come from. We find that among women of color, the rates tend to be higher than among white women. And so it is very dependent. For example, in London, I know there are places in London where the prevalence is extremely low, and so screening's not really worthwhile. But there are other neighborhoods in the same city where the rates are very high. And so understanding and working with the clinical providers that send specimens to your lab, you can help them make their own clinical decisions about who they should be testing based on what they see in their populations.
Great, thank you for that clarification on a very complex question. So the next question is also for you, Bobby. Why don't we screen for myeloplasma?
So mycoplasma screening is not particularly useful at this time because we don't have information about complications that may arise from asymptomatic infection. It appears that people may self-clear this infection. And if that's the case, natural clearance is preferable to antibiotic use because this organism does develop resistance so quickly. So when there are no long-term consequences, now, if we find different data, and one of the reasons we should continue looking is if we find out that there are outcomes similar to those with asymptomatic chlamydia infection that include infertility or chronic pelvic pain and pelvic inflammatory disease, then perhaps we will change our opinion about whether or not screening is appropriate. But at this time, it's really only useful in symptomatic people based on the knowledge we have today.
Great, thank you. So Bina, this question is for you. It's basically a two-part question. What assays can we run together on one plate?
So in general, as long as the assays are validated on the same instrument and are using a universal profile that I showed in the slide before, that's in case of if you want to mix the DNA and RNA applications together, they all can be run together. It's the universal internal control is good with most of the microbiology kits that we offer in our portfolio.
Right, thanks. And the second part, how many specimens can be done per sample?
We actually have multiple validated specimens that have been tested for the different assay kits. So that really provides flexibility for the laboratory, flexibility to collect samples from wide range of, collection methods, or, if, we are using blood as an example, it can be used for multiple assays. One sample, you extract the DNA and can be run on, multiple tests. So please refer to, our webpage and iFew to see which samples are validated for each of the assay kits that you want to use.
Great, thank you. And as a reminder, we have questions coming in, but please feel free to ask your questions. We have about 8 minutes left, so we will try to get to everything we can. So this next question will actually go towards, part one will be towards Bobby, part two will be towards Bina. Bobby, what is the ideal sample type being used and why, if you could only choose one?
Well, if you can only choose one, for people with a vagina, a vaginal swab is going to give you the most sensitive results possible and allow you the broadest range of pathogens to test for, because you can test for STIs and you can simultaneously test for causes of vaginitis. For men who have sex with women, urine specimens are ideal and easy to collect, and they're acceptable to most men. If you could only do one sample type for men who have sex with men, you probably wanted to use a rectal sample. But in that case, you would only be testing for chlamydia, gonorrhea, and not any other pathogens.
Thank you. So Bina, can you chime in on how this mirrors the GeneProof sample types?
Yeah, so, as Dr. Vanderpool said, that urine and swabs are, the two most common sample types used. All our TaqPath Menu PCR kits are validated on both urine and swab. So we have, both the options available for laboratory users to use all our kits. We support both urine and swab for all the kits.
Great, thank you. So Bobby, this question is for you. This is basically a wish list question. What are the testing gaps in STI? If you could have any test that doesn't currently exist, what would it be?
I think that's really hard. I think we're actually in such good shape right now with the pathogens that we can detect. I think if I could have anything that I wanted, I would have a pooling system so that I could do 3-site testing from people from one tube. So maybe you have a urine and a rectal swab and a throat swab, but they all go into the same tube, and there's then the testing done from that, because it would, for public health purposes, save everybody so much money, but it would really give us more comprehensive care so that we could test all potential sites of exposure, depending on, how people engage in sexual activities. And obviously that's something their clinician would have to be asking about. But I think that is a huge missing need. The second thing that I think is really huge and missing in some places is the ability to collect specimens at home and mail them in. Europe is much further advanced in that because they've been doing that for 20 some odd years, where in the US we can't get it off the ground. So, in some settings that's already there. But I think obviously the next step will be at-home testing. And I think laboratorians need to remember that at-home testing is actually going to impact laboratory services as well. Because when a person tests at home, it's unlikely they're going to just be written a prescription based on what they say they tested for, because they may need to be tested for other pathogens as well, since co-infections are so likely. So the labs are going to be needing information about whether patients have self-tested, because if there's discordance between the patient's self-test results and the laboratory generated results, the laboratory is going to be the one stuck kind of holding the bag, trying to answer questions about it. So I think understanding the clinical and testing history of patients is going to become more important than it's ever been for laboratories. And I'm sorry, that was a very long-winded answer.
That was great. Thank you so much. So can you talk a little bit about direct antibiotic resistance testing?
Bina, do you want to take that, or do you want me to?
You can go ahead, Dr. Vanderpool.
So for several pathogens, and depending on where you're working, there are assays on the market that can test for resistance markers for mycoplasma for macrolide resistance, and resistance markers in gonorrhea for ciprofloxacin resistance. So you can do this directly from the sample without ever having to go through culture, which is a huge advantage because of the turnaround time, which means you can appropriately treat the patient. The thing to remember about testing for antimicrobial resistance markers is that they are just that. They are markers. And so not everybody who has that genetic marker will fail treatment. But so if instead you're looking for, can I use an older treatment, and you see only the wild type in that patient, the chances are good that you can use an older treatment. So that's the positive news. But we have to remember that it's all still sort of up in the air and developing. And I think that's another area that is somewhat of a gap and that we need to close fairly soon.
And just to add, we do have, antibiotic resistance testing, kits available. So, if users are interested, please visit the thermofisher.com website to look at the menu offering for the antibiotic resisting testing.
Great, thank you. It looks like we are just right out of time. So I want to again thank you, Dr. Vanderpool and Bina, for your time today and your important research and presentation. We'd also like to thank LabRoots for presenting this program, which was sponsored by Thermo Fisher Scientific. Before we go, I'd like to thank the audience for joining us today and for their great questions. Questions that we have not had time to answer today, and those submitted through the on-demand period, will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, please take care, everybody. Goodbye.